Good morning, good afternoon, good evening po sa lahat. Welcome po sa ating 111th episode of the Stop COVID Deaths webinar series brought to you by the University of the Philippines. Thank you for being a part of our credible online community, and for all those who have just discovered us for today, welcome po. At sana po magustuhan po ninyo ang ating topic for today. Very timely po because it has been recently declared as a global health emergency, and it's very incumbent upon us to learn more about it, lalo na po baka po it might be, sana hindi naman, pero it might be a COVID-19-like situation po. On July 23rd of this year, the World Health Organization declared monkeypox as a public health emergency of international concern. The first case of monkeypox detected in the Philippines was reported to be a Filipino national. So, baka po kasi may mga nagtatanong pa po kung nandito na po ba si Pilipinas o hindi. Yes, nagkaroon na po tayo ng kaso ng monkeypox. This Filipino national traveled to other countries with documented cases of monkeypox. So, simula nun, since then, there has been a report of a Filipino who contracted the disease na rin po in Singapore. Marami po ang nagtatanong sa atin, handa po ba tayo? Should there be more cases of monkeypox na pumasok po or magkaroon po dito, let's say community transmission dito sa Pilipinas? What type of protection and maybe mga precaution po should health workers take para po bumaba po ang kanilang risk of transmission? Available po ba, katulad po ng COVID-19, available po ba ang bakuna dito sa Pilipinas? At meron din po ba tayong mga gamot kung magkaroon na po tayong monkeypox, meron na po ba dito sa Pilipinas? So in this episode of the Stop COVID Deaths webinar series, we will take a closer look at the state of the art and science for the monkeypox infection po. I'm Dr. Raymond Francis Sarmiento, Director of National Telehealth Center, National Institutes of Health, University of Philippines, Manila. Always a pleasure to be with all of you during our regular Friday po, no? Always looking forward to Fridays because I get to share hosting duties. Kita nyo naman ang aking partner for today. She is our adjunct research faculty at the National Telehealth Center. Also, international renowned in public health communications, Dr. Susie Pinedo Mercado. Dr. Susie?
Hi Raymond. Good afternoon. Kamusta ka na? And sa lahat sa inyo ang nakikinig, kamusta kayo Raymond? Nakakatakot ka naman na magiging parang COVID yung monkeypox. Hindi naman siguro.
I'm just putting it out there kasi syempre, parang ganyan
Okay.
We are just coming out from...
So, yeah. I mean, I think we need to be prepared and we bring you only the best speakers. Today, you're gonna have two experts that you really, really like. I know, paborito nyo sila. And sana hindi totoo yung sinasabi na, well, I think that the feeling is, hindi pa tayo tapos sa COVID, may monkeypox naman, di ba? So parang, what do we need? What do we need to do? What do we need to know? And the Raymond, we actually talked about monkeypox a couple of months back, right? We talked about this already.
Dr. Tayag, I believe so. Yes.
Yeah. And at that time, there was very little known about it. Kasi kakaunti lang ang merong monkeypox noon, ano? So, napag-usapan nga noon na hindi naman ang galing sa monkey, sa squirrel ba? Ano yung sinabi ni Eric? Squirrels, rodent.
Yes, opo.
So we wanted to talk about it kasi we said, okay, this might be something, right? And it turned out to be something. And I think Raymond is correct na parang we have to know more. We have to, kailangan anuhin natin yung situation and parang agapan yung sitwasyon para hindi pa nga tayo tapos sa COVID, no? Anyway, so you've noticed that in the opening billboard, Stop COVID Deaths stands for C is for continuing COVID concerns, no? Tapos O, other outbreaks, V, viruses, I, infections, and D, disasters. Last week, maganda yung natin on disasters. Ngayon naman, balik tayo sa mga other outbreaks. Ito na ngayon yung sa monkeypox. But, we know that you really like to know the news and discern which is fake news and which is totoong news. And so for this purpose, we have created a new section called the News Update.
Okay, thank you so much, Dr. Susie. This one po is really very new. it's coming in ano po, with regards to Omicron, ang pinaka-favorite po natin na subvariant. Part of it really is to be able to understand ano pa po ba yung mga hindi pa po natin alam patungkol po sa Omicron. Pero meron po dito, sabi po, Omicron is better at invading young noses than other variants, and smell loss may predict memory issues. So may mga sinasabi po na may mga pag-aaral na nagsasabi po na if one of your symptoms, of if you had experienced loss of smell, meron po itong association with regards to cognitive impairment or memory issues po, yung pong magiging makakalimutin. So that's something to really look and be aware of, especially for those who are experiencing long COVID, those who, because we've had cases po, or at least we've heard of cases wherein matagal po bago po nila na-recover yung kanilang sense of smell and then sense of taste po in as a corollary. So that is something that we continue to monitor, and hopefully if there are any new, let's say baka for other subvariants or anything of that sort that may be new to us, na that will be helpful in terms of how to build our immunity and how to maybe predict kung magkakaroon po tayo ng mga ganito, especially as part of that spectrum from long COVID. Stop COVID Deaths team will be there at the forefront in letting you know about all of these things. Dr. Susie, what is your news update po?
Yeah, thank you, Raymond. Well, on the international front, India confirms the first monkeypox death in Asia. So India confirmed its first monkeypox death on Monday, August 1, a young man in the southern state of Kerala, in what is only the fourth known fatality from the disease in the current outbreak. Last week, Spain reported 2 monkeypox-related deaths, and Brazil also reported its first. You'll recall that the World Health Organization declared the outbreak a global health emergency on July 23. So the first death in Asia. So that's our news for today, and next week we'll be back with more updates for you here on the News Update. Okay, Raymond, tuloy-tuloy tayo, no? We go back to our topic, which is, well, I was talking about monkeypox on the news, but we talk about monkeypox here, here in the Philippines. And, you know, Raymond already talked about one reported case in our country, and we have seen the news, how it's spreading all over the world. So we're going to learn more about that today with our experts. But before that, we always like to listen to what people are thinking on the ground, Raymond, di ba?
That's true, Dr. Susie. And for all those who are joining us for today, we like to set our discussion into context by showing you a very short video that was cobbled up by our very hardworking team sa TVUP po. Really trying to get the pulse of the common folks on the street. And the question that we pose to them, how do you think, sa palagay po ninyo, monkeypox can be prevented? Please watch this.
Alam ko, it's a disease na may symptoms na rashes and could be actually contagious and could be deadly.
As a public, kasi ongoing pa rin naman ang COVID, yung minimum standards na ginagawa natin sa COVID, pagpatuloy lang din. Kasi kung di ako nagkakamali, ang na-i-share yung virus ng monkeypox through close contact din, body fluid ganyan, respiratory. Kaya kung in place din naman yung mga minimum standards natin for COVID, I guess that's good enough.
Mabilis kumalat ang balita dahil marami ng social media platforms aside from the television. So, mas madaling nadi-disseminate na yung information sa mga tao.
Tutulungan mo ngayon yung sarili mong makahanap ng mga impormasyon para mapalawak mo yung kaalaman mo tungkol sa sakit na yan. Sa pagiging curious mo at sa pangangalap mo ng impormasyon, dyan ka maililigtas para hindi ka mawaan ng monkeypox.
Awareness in a way na even sa media platform, and locally. Tapos, to establish the safety protocols na rin.
Yung paunang prevention is siguro yung pagbaban ng mga citizens ng mga infected na mga bansa na.
Ganun eh. Sila dapat dun eh. Sila dapat sa gobyerno, frontliners, yung unang maghanap ng solusyon para hindi makapasok dito yan.
May trauma na from the past, itong ongoing pandemic, kaya para sa akin siguro dapat hindi man lockdown, more on closing borders, lalo na din sa mga mataas ang kaso ng bansa.
Dapat meron ka rin contingency plan. So you have to fix your healthcare system then in the Philippines.
I think ang mga doktor or those in authority, alam na nila kung ano kailangan gawin. Yun nga lang din, kailangan proactive sa mga natin para pang araw-araw.
Alam na ng tao kung paano mag-iingat. And yung monkeypox kasi is hindi naman siya ganun kalala. I mean, unlike COVID na yung fatality rate is masyadong mataas.
Okay, thank you very much, TVUP. Oh, I love their insights, Raymond. Galing, Parang, parang pinag-iisipan din nila kung ano yung ginagawa na ngayon na makakatulong. And it looks like people are monitoring it, no, Raymond? What do you think?
Yes, Dr. Susie, I think hindi po siya parang mindset is COVID pa rin. They are very, very wary of what is happening. And even a single case, kasi dati nung COVID parang it's not this level of heightened alert, I mean on an individual level po, no.
Yeah.
For monkeypox iba eh. They are after COVID iba na po yung dating talaga niya, especially since it's another global health emergency that has been announced.
Oo, parang I think Raymond, I think people are sensitized now to pandemics and epidemics. So ngayon parang meron ng sense na okay, kailangan nating mag-ingat, ganitong gagawin natin. But of course, there's a lot we can learn from recent research, from cases that are happening abroad, and from treatment that's being done abroad. So that's why, we bring you only the best today. We're also going to hear anong paghahanda na ginagawa sa Philippine General Hospital, no? Kasi that's one of our, that's our kind of like our mataas ang antena ng PGH pagdating sa mga ganito, no? So we will, we're going to go to that, but I think, Raymond, you're gonna do some housekeeping. Housekeeping tayo. Sige.
Yes, Dr. Susie. So for all those who are asking and who keep on messaging us din po sa Messenger, really emailing, certificates of attendance po will be given to those who have watched at least 50% of the webinar duration. We have completely sent out for webinars 109 pababa, lahat po ng certificates. Meron pa lang pong konting-konti na lang na natitira for webinar 110 which was last week. So kung hindi nyo po siya natatanggap pa, abangan nyo lang po siya sa inyong inbox, but it should be in your inbox very very soon if you have not yet received it. And hopefully at the latest either Sunday or Monday po ay nandun na po iyon sa inyo. For today's webinar, again, we will be following our standard panel discussion format. We have a set of speakers presenting, followed by a Q&A session wherein we'll be entertaining questions, not just coming from the Zoom, but also in our live stream links for Facebook and in YouTube. Over to you, Dr. Susie.
Okay, meron dalawang makulit dito na i-introduce yung ating fan quiz. TVUP, take it away. Hello?
Kumusta na kayo lahat?
Hi, I'm Doc Susie, the mini Doc Susie.
And I'm Doc Radar, the mini Doc Raymond. Are you ready to have fun? Simply open your browser to www.slido.com and enter your code to participate. We will discuss your answers during the panel discussion later on in the program.
We will have it flashing on your screen in a bit, and we look forward to your answers. Masaya at madali lang ito. Join na! Ang kulit, Raymond?
Tayong dalawa
Sige,
pala
go.
yung makulit na yun.
Yung dalawang makulit na yun, makukulit yun. Okay, Yes.
Can we have the poll also? There we go on Zoom. Thank you so
Okay.
much. For those who are outside of the Zoom po, no, you can still participate in our fun quiz. Open up your internet browsers and type in slido.com, and when you're prompted, input the code 5405717. That's 5405717 for you to be able to participate in our fun quiz. We have two questions for today. The first question is, how is monkeypox transmitted? Option A po natin ay nakalagay prolonged physical contact, skin to skin. Yan po yung unang-una. Pangalawa, fomites. So, sa mga tuwalya, sa mga damit, sa mga bedding, dun po ba siya nakukuha? Pangatlo, respiratory droplets. At pang-apat po ay all of the above. Before we move on to our second question, I'd like to greet those who are joining us from CHD in Region 1 in Binmalay. I hope I'm pronouncing that correctly. Binmalay, Pangasinan. From the Pasig City Health Office in Pasig po, UP Visayas Health Services Unit in Miagao, Iloilo, Riverside Medical Center Incorporated in Bacolod, Negros Occidental, Adventist Medical Center in Valencia City, Bukidnon, and Davao Doctors Hospital in Davao del Sur. Greet ko rin po, ito po, lagi po nanonood po sa atin, no? Okay. From the Center for Kidney Diseases of the University of Santo Tomas. So maraming salamat po. May nanonood din po. Etet Tahil from Sarangani, from Southern Philippines Medical Center in Davao, Quirino Memorial Medical Center, Ward 10 ng Philippine General Hospital, Lalo ba to? Rural Health Unit. Thank you so much for sa masugid na pagsubaybay at panonood. We'd also like to greet the Pathology Department of the Philippine Heart Center. Ito pong mga kung saan po nagtatrabaho ang aking asawa of LFW Hospital in San Fernando, Pampanga po. Hello po sa inyo. Those who are watching also from Lasal, Dasmariñas, those from Cebu, from the COVID lab in Santa Rosa, CHO1, I hope that's correct. From Paco, Manila, also from JMS Healthcare Philippines Incorporated in Batangas, and Camarines Sur. I think that's the farthest that I can go po. NICU ng PGH also watching. OPD PGH UP Nismed. Ay wow, ayos. Thank you so much from Angeles University Foundation, from the Department of Social Welfare and Development as well. Philippine General Hospital OPD Pharma Unit. Thank you so much. The PINAY NHSRC of the National Institutes of Health in UP Manila, Lung Center of the Philippines, and Philippine Children's Medical Center Rehab and Dialysis Coalition of the Philippines. For our second question deals with this one. Ano po ba ang dapat gawin ng mga healthcare workers? What should the healthcare workers use when seeing a patient suspected to have monkeypox? Dapat po ba silang gumamit ng gloves? Mag-gown po ba sila? N95 mask? Eye protection? Or all of the above? Ito po ba ang kanilang mga kailangang gawin? I've seen those who are watching us. I think there's one from Micronesia. Ito po, bago, Western Visayas State University Medical Center. Thank you po, and UPCM admin. We have one from Micronesia, from Hail, from the US Navy base, Diego Garcia. Okay, from Chonin Hospital in Taipei City, Taiwan. Kanto City in Vietnam, Jakarta, Indonesia, University of Hail, and King Abdulaziz Medical City in Riyadh in Saudi Arabia, Philippine Nurses Association in Edmonton, Alberta, Canada, Albany Family Medicine in Albany, New York, Potts Point in Sydney, Australia, and Nepucos Bueno, Federated States of Micronesia. Baka siya po yung kanina. So maraming salamat po. We will not be closing this poll just yet. Because we want you to be able to participate po, no? Marami pa rin po yung trickle in na papasok po dito sa ating Zoom at least, and also in our Slido. And I'll turn the floor over to Dr. Susie for our webinar proper.
Thank you so much, Raymond, at maraming salamat to everyone who's watching from many different parts of the world. Filipino health workers, a lot are tuning in to us, no, both on YouTube. So, kamusta po sa inyong lahat? And we really hope that this afternoon, this noontime break will be very productive for everybody. because we've got great guests. So we only bring you the best. Our first speaker is somebody you know very well and one of your favorites. He is a US-based infectious disease specialist and has really been helpful to the whole community, to our Stop COVID Death community. Kasi nadadala niya yung na-explain niya sa atin yung latest developments internationally in terms of clinical care and practice. So, hindi pa dumadating dito, nabibigyan niya na tayo ng idea, no, what's going on, what we need to do. So, we're just so grateful to him for, you know, coming on the program anytime we ask him. And even if it's late in California, he joins us. So, let's welcome your favorite, Dr. Franco Felizarta. Franco, welcome to the webinar.
Thank you.
Thank you for the kind introduction, Dr. Susie. Let me share my.
Yeah, go ahead. Go ahead.
Screen.
Okay lang, take your time.
I'm becoming
Okay.
rusty with this.
Go ahead, Franco.
Okay, so you can
There
see
you
it
go.
now, right?
Perfect.
Okay. So magandang hapon po ulit sa inyong lahat. So today I will give you an update and a comprehensive review of the monkeypox outbreak. I have about 50 slides, but hopefully we can finish this in 25 minutes. So these are my disclosures. I've participated in more than 180 clinical trials, mostly on HIV, Hep C, and lately COVID. I also participated, several years ago in a clinical trial by Bavarian Nordic, the makers of Janius. So this is on the use of monkeypox vaccine in HIV-infected individuals. So I will discuss the history first, virology, transmission and epidemiology, clinical presentation, diagnosis, management, and immunization. So it's a comprehensive review. So let's start with the history first. Monkeypox is really not a new virus. It was identified in 1958 in non-human primates that were kept in a research facility in Denmark. The first human case was reported in 1970 in the Democratic Republic of Congo, which is formerly the country of Zaire. So over the past 50 years, sporadic outbreaks have been reported in 10 African countries. It's endemic in those 10 countries, typically originating from contact with wildlife, particularly rodents. So this is a zoonotic virus. Outbreaks outside Africa were linked to travel or importation of animals. Now, way back, we already know monkeypox has the potential to spread worldwide due to deforestation, encroachment on animal habitats, population growth. These are the usual, increasing human mobility and enhanced global interconnectedness. Now, the 2022 outbreak started in May of 2022. I think the first case was in May 7 in the United Kingdom. As of now, August 4th, there's 26,864 cases in 95 countries. So 88 non-endemic countries and 7 endemic countries. There's 345 and about 26,000 for the non-endemic countries. In terms of death, there are now, I think, 10 deaths reported, 10 deaths, 6 in endemic countries, 5 in Nigeria, 1 in Ghana. And then for the non-endemic, there's 4 deaths. The one from India that was mentioned a while back, and then 1 from Brazil and 2 from Spain. So that's 6 out of, for the non-endemic, it was 6 out of 345. So that's about 2%, but much lower outside of the endemic country. So it's 4 out of 26,000. So that's less than 1 in 1,000 in terms of mortality rate. Now, WHO declared monkeypox as a public health emergency of international importance on July 23rd. It was just declared an emergency here in the United States today, August 4th, 2022. So let's look at the virology now. These are the pox viruses causing infection in humans. So monkeypox virus is one of them. It belongs to the Poxviridae family and the genus Orthopox virus. So the Orthopox virus is a genus consisting of variola, which is the smallpox. So remember, this is already eradicated. There's cowpox in Europe and vaccinia-like viruses like buffalo pox in India, and these two are from South America. Molluscum contagiosum is a pox virus, but it's not an orthopox virus. It's a different genus, and it's the most common pox virus in the world. It's a benign viral infection in children. It's solely a human pathogen, just like smallpox. All the rest are zoonotic viruses, meaning they have animal reservoir. So orthopox viruses are large, double-stranded DNA viruses with a brick-like structure. So it looks like this, and in a genome that codes for about 200 genes. So this is much larger than your COVID virus. Now, orthopox viruses exhibit immunological cross-reactivity and cross-protection. This is very different from coronavirus, where the cross-protection is not substantial. Now, even with that, a large proportion of the global population does not have immunity anymore against zoonotic orthopox virus and variola, which is smallpox, due to termination of the smallpox vaccination programs over 40 years ago. Remember, it was eradicated in 1980. So in the United States, they terminated in 1972. I think in the Philippines, they terminated the smallpox program in 1977. So 40 years ago, 80% of the population was vaccinated against smallpox. Now it's about 30%. So there's a lower percentage of the population that has smallpox vaccination, and therefore lower cross protection between smallpox and monkeypox. This is the structure of the virion. The nucleic acid is surrounded by a core membrane, and you have this distinct lateral bodies, and then you have this outer envelope. So this is much larger than your COVID virus, actually one of the largest of the viruses. In terms of replication, suffice it to say is actually all of them, the replication cycle is in the cytoplasm. It doesn't include the nucleus. So let's discuss the transmission now and epidemiology. So this is quite important. So the transmission of monkeypox occurs through large respiratory droplets. But usually this is during prolonged face-to-face contact or during intimate physical contact, such as kissing, cuddling, or sex. Okay, so prolonged face-to-face contact, close or direct contact with skin lesions. So this is the primary transmission route, is the direct contact with skin lesions, and possibly through contaminated fomites. So it could be clothing, towels, bed linens, drinking glasses, even dishes or eating utensils. But I think the contribution from contaminated fomites is pretty low, just like COVID. Animal to human transmission occurs via bites and scratches. Monkeypox has a wide range of potential host organisms, including squirrels, monkeys, and possibly mice, rats, and rabbits. So, but a definitive animal reservoir has not been identified yet. Now, this one is just showing you that the spillover events in endemic countries, the spillover events occur from zoonotic animal reservoir. So here, the example is a monkey and a squirrel. But for outbreaks in non-endemic countries, it's usually from global travel. So usually from a traveler or from a research animal importation. So monkeypox virus is endemic in 10 countries in Central and West African countries. The most important is the Democratic Republic of Congo, or DRC, okay, because most of the cases, almost 90% of the cases are in DRC. Now, there are 3 distinct genetic clades of the monkeypox virus, so like 3 subgroups, okay? So clade 1 is the Central African or Congo Basin clade, and clades 2 and 3 are both the formerly designated West African clade, but these are still popular, the Central African and West African terminology. Now, the 2022 outbreak, the one that's ongoing right now, belongs to the clade 3, which is under the West African clade. And potentially, it represents a continuous circulation and evolution of the virus that caused the 2017-2018 Nigeria outbreak. So it's been there, actually. It's been there. It's just the difference, though, is there's a lot more mutations from that related virus. So instead of 1 to 2 substitutions per year, so that's from 2017, that's 5 years, there should only be 10 mutations, and this one already has 50 mutations. So it looks like this particular you can call it subvariant has accelerated evolution. We don't know the implication of this yet. We don't know if this actually increases the transmissibility of monkeypox. Now, these are the map of countries, and these are the endemic countries in Africa and the number of suspected cases. So I already mentioned this is Democratic Republic of the Congo, which is formerly Zaire, has most of the cases. So all of these Central African nations have the clade 1, which is the and all the Western countries is clades 2 and 3. So that's Nigeria is the predominant one for clades 3. Cameroon is the only country with 2 clades, clades 1 and 3, which is not surprising because it's in the middle between the Western and the Central African nations. Now the previous one is up to 2018. This one is up to 2021. So there are more cases here. Before it was 26,000. Now it's almost 40,000 for DRC. In Nigeria, went up just a little bit to 74, but this is the Western clade. And for non-endemic countries, remember most of the non-endemic outbreaks are from Nigeria, from the Western clade. So United States has the most, 49 cases. This is before the 2022 outbreak. There's already 29 cases in the United States from 2000 to 2021. Now, this is the case fatality rate. Now, this is the mortality rate in monkeypox cases. So overall, it's 8.7%. That's pretty high. The Central African clade is higher, 10.6%. And the West African clade, this is from Nigeria, where the 2024 outbreak came from, is lower at 4.6%. Now, 4.6% is still pretty high. Remember, COVID mortality rate is 0.1 to 1%. But remember, this is probably an underestimation because we know in Africa the diagnosis of monkeypox is underdiagnosed probably 5 to 10 times. So this is probably the the true case overall mortality rate. The infection mortality is probably less than is probably about 1 to 2% for Central African and less than 1% for the West African clade. Now, the other explanation why the case fatality rate is higher in Africa is because the African population is much younger. And if you have a younger population, the case fatality rate is higher. So for example, in the DRC 1981-86 outbreak, all the deaths are in unvaccinated children 3 months to 8 years old. So when they're less than 2 years old, the mortality rate is 20%. If there's 5 to 9 years old, 6.6%. This is pretty high. But remember, this is probably overestimated because it's underdiagnosed in Africa about 5 to 10 times. So, but even if let's say the case mortality rate is 1 in 100, let's say the infection mortality rate is 1 in 100, that's still higher than COVID. In children, the COVID mortality rate is 1 in 10,000. So that's still much higher than COVID. So this is very different from COVID. So in COVID, the highest mortality rate is in the elderly, okay, up to 20%, and much lower in the children, 1 in 10,000. In monkeypox, it's different. The older you are, the lower the mortality. The younger you are, the higher mortality. It's probably because of the prevalence of smallpox vaccination. Now, this one is just trying to explain the outbreak in Nigeria in 2017 to 2018. This is the source of the 2022 outbreak. This is showing the relationship between the population and individual level smallpox vaccination and immunity rates. So let's start with the individual immunity level. It starts at 85%. We will discuss this later, because this is based on a study showing that the cross protection rate between smallpox and monkeypox after smallpox vaccination is 85%. Okay, so of course for smallpox it's 100%. For monkeypox it's 85%. Remember, the smallpox vaccine is vaccinia, not variola. So 85%. It decreases 1% per year, and so by 2017, the protection rate is already less than 20%. So it's much lower compared to before. There's still protection, but it's much lower. So that's the individual immunity level. If you look at the population immunity level, it will be much lower. Why? Because of population growth, and the people who had smallpox vaccination before are getting older, and of course there's increased mortality for those people because of aging. So there's less and less people who had smallpox vaccination. So in 2017, less than 5% of the population had smallpox vaccination, probably initiating the outbreak. This is a second way of explaining the outbreaks. This one, they use the Democratic Republic of Congo, DRC, as an example. So in the x-axis is the immunity in population to orthopox viruses. This is because of smallpox vaccination. And in the y-axis is our familiar R, which is the reproduction number. So in 1980s, there was a high immunity rate, more than 80%. So the effective reproduction number is less than 0.5. In 2011, it went down to 60%, increasing the reproductive number to more than 1. Remember, if the reproduction number is more than 1.0, you can initiate epidemics. Right now, it's probably less than 10%, like Nigeria. Remember, worldwide, the smallpox vaccination rate is still much higher than Africa. It's about 30% worldwide. In Africa, it's probably less than 5%. Now, it's still unlikely that these outbreaks will lead to a global pandemic similar to COVID-19. Why? Because there's several explanations. One, monkeypox virus is not a novel virus. We're not immunologically naive to monkeypox virus. Remember, it's already endemic in some African countries, and still 30% of the world population had smallpox vaccination. It's also a DNA virus, so it has a lower mutation rate, probably 10 times lower than RNA viruses like COVID or flu. Transmission is different from SARS-CoV-2. There's no airborne and there's no pre-symptomatic transmission, okay? And also, patients with skin lesions can be isolated more effectively. Third reason is the basic reproduction. Should be reproduction number is only 2.1. Okay, this is based on the study, previous study here, 2.1. The 95% confidence interval is 1.5 to 2.7. So this is much lower than the Omicron variant, which is up to 22.5. Remember, measles is 18, so the Omicron variant is much more infectious now than measles. It's probably because of immune escape rather than transmissibility. And of course, antivirals and vaccines are already available for monkeypox, although the supply is very limited, and we'll talk about this later. So let's. I think this is the most important one. This is a clinical presentation. So how do you diagnose monkeypox from the clinical presentation? So historically, patients typically presents with prodromal symptoms. So you have fever, headaches, malaise, and lymphadenopathy, followed by the rash. So you have a prodrome and then a rash after a few days. Okay, usually within 5 days. The rash usually starts in the mouth and spreads to the face and extremities. And then the palms and the soles. So this is the centrifugal pattern of the rash. Pain can be prominent, but it's not universal. And then of course, itching can occur if the lesions are in the healing stage. The number of lesions is quite large, 10 to 150. Some of them have more than 200. It can persist up to 4 weeks, so it's 3 to 4 weeks. Patients are infectious from the symptom start. Okay, now the symptom start may include the prodromal symptoms before the appearance of the rash. This is controversial though, okay? Now, it's also infectious until the lesions scab and fall off with a new layer of skin being formed. Okay, so this is the infectious period, but most of the infectious period is during the macular to pustular stage, and we'll talk about that later. Rare complications include bacterial superinfection, conjunctivitis, keratitis. We see this a little bit more often, and encephalitis, pneumonitis are very rare. So this is just a summary. Okay, so this is the stages of skin presentation progression of the rash. So you have macules, papules, vesicles, pustules, and scabs. So in the first week, from macules to vesicles, it takes about a week. Another week of pustules, and then 1 to 2 weeks of scabbing. So overall, it's 3 to 4 weeks. Okay, that's the progression of the monkeypox. So it's a firm, deep-seated, well-circumscribed, umbilicated, small lesion. Okay, it's less than 1 centimeter. The important thing to remember here is it's umbilicated, because this is not common, especially in genital lesions. So you can see it looks like a volcano here with a big, with a big crater. Okay, so that's you can distinguish monkeypox with this umbilication, and it's a wide umbilication. Now, remember, those are the historical presentation. It looks like the 2022 outbreak has a different clinical presentation. It may be because of the demographics. So this is based on 528 infections from 16 countries. This was just published in the New England Journal of Medicine, July 21st. So 98% were MSM, men who have sex with men. 41% had HIV infections, almost half. And the age range 21 to 62. So 38 years is the median age. Okay. Sexual activity, 95%. 64% have less than 10 lesions. Remember, historically, it's 10 to 150. Here, 64 majority of the lesions are less than 10, so it's much less. 73% have anogenital lesions. So historically, it starts with the mouth and face, but here, 70% are anogenital, and 54, that's 10%, have a single genital lesion. So that's similar to primary syphilis. Primary syphilis is usually one single genital lesion, so you have to be careful. You have the systemic features, which is the same. Concomitant STI, sexually transmitted infections, in 29%. So almost 1/3 have concomitant sexually transmitted disease. So they either have syphilis or herpes or chlamydia or gonorrhea. So it's very important to check for other STIs. The median incubation period is about 7 days. It's 3 to 20, so it's up to 3 weeks. The historically the incubation period is slower at 12 days. This is much faster at 7 days. Now this one, we don't know the implication. DNA was detected in almost all the persons on whom the seminal fluid is analyzed. So we don't know this replication competent, but it really looks like a sexually transmitted infection just based on this. We still need confirmation if it can be really transmitted through the seminal fluid. Positive PCR results in 26% of nasopharyngeal specimens. So, remember, it can be transmitted through large respiratory droplets. Hospitalization in only 13%. Okay, so mostly for severe anorectal pain because the lesions are there. Superinfections, pharyngitis, limiting oral intake, and eye lesions. Now, no deaths were reported in this series, but remember, there's already 10 deaths out of 26,000. Still, the mortality rate is quite lower compared to Africa, so less than 1 in 1,000. So 96% of those with HIV infection were taking antiretroviral treatment. So they're on HIV drugs. This is important because in Africa, where most of the deaths in adults happen in HIV positive patients who are not taking HIV medications. Okay. Pre-exposure prophylaxis for HIV has been used in the month before presentation, 57%. So they're really high risk for STI. Lesions in multiple places were present simultaneously. Historically, there's a progression. You already seen it a while ago. There's a progression from macules to vesicles to pustules. Here, you can have a scab in the face and a pustule in the genital area. It could be present simultaneously. So it could look like chickenpox or even herpes zoster. The presenting symptom in 61 persons, so that's about 10% of the patients, is anorectal pain. So there's proctitis, tenesmus, or diarrhea, or even rectal bleeding. So it means the lesions were inside. Okay, it's probably in the rectal region. You won't even see it. So they actually presented as anal pain. Pharyngitis in odynophagia and epiglottitis and oral tonsillar lesion is 26 persons as a initial presentation, and then rarely conjunctival mucosal lesions as the initial presentation. There's lesions with prodrome occurred 17 of 30 persons, but there's 13 persons where there was a single lesion without a prodrome. Okay, and the latest time point at which a lesion remained positive was 21 days after symptom onset. So it can still be positive. So if a patient comes in with a late presentation, let's say even if it's scabbing, still you can still do a swab, and you can most likely you'll get a positive test. Even if the patient comes in with a late presentation. In my practice, I already diagnosed three patients with monkeypox. My first patient presented with 2 non-tender umbilicated pustules in the penile shaft, and he had a headache 2 days before. He had a smallpox vaccination when he was much older, so he knew that he had a smallpox vaccination before. My second patient presented with 4 non-tender umbilicated lesions in the base of the penis, a erythematous papule in the arm, in the left side of the trunk, and he had a lesion in the right tonsil. He actually presented with sore throat. Okay, he had sore throat first, but he has no prodromes, no headaches, no fever, and no lymphadenopathy. My third patient presented in a very atypical way. He had a very small but still umbilicated pustule in the urethral opening. He presented with dysuria. He had burning urination, but no pus, just burning urination. And then when I saw it, there's actually a lesion there in the urethral opening. So you can have a lot of atypical presentations. So these are just examples from the New England Journal publications. This is the facial, this is the genital. You can see the umbilicated pustules. This is more examples. This is around the mouth, the tongue, and the tonsillar area. So remember, these patients can present. If it's not around the mouth, they can present as a sore throat. And this one are a perianal, anal, rectal lesions. So remember, a patient can just present with anal pain, and there will be no lesions there because it's inside. But most of the time, though, you'll see some umbilicated lesions in the perianal area. So differential diagnosis, of course, is important. There's a lot of this, but I think the most important is herpes and syphilis. Remember, herpes is painful and syphilis is non-tender. So if you have a patient with a non-tender umbilicated, non-tender lesion in the genital area, especially if it's a single lesion, it could be herpes, but it could also be monkeypox. Remember, the difference is the umbilication. Herpes is painful, and remember, in the anal area, the monkeypox lesion is very painful. So in the anal area, it could look like herpes. So it's very, very important that if you see a patient for if you're having suspicion for monkeypox, you still have to check for other STIs. The most important is the syphilis serology test, and if you have the PCR for herpes. Now remember, if you have a rash, that could be secondary syphilis, and you still need to do a syphilis serology test. So diagnosis, this is the at least this is for CDC. A suspected case is if you have a rash and epidemiologic criteria. A probable case if the patient did not have a vaccine, but they have a positive orthopox virus DNA. And a confirmed case is if you have a positive monkeypox DNA. And a lot of the laboratories in the United States are already doing the monkeypox virus DNA. The health department does orthopox, and then they send it to CDC for the monkeypox virus DNA. So it's much faster with the local labs. Epidemiologic criteria within 21 days, because the incubation period is up to 3 weeks. Of course, if there's a contact with a person with similar appearing rash, or of course confirmed monkeypox. Intimate in-person contact with individuals in a social network experiencing monkeypox activity. Travel outside the US in a country with confirmed cases of monkeypox, and had contact with dead or live wild animals that is an African endemic species. Okay, so my 3 patients, the first one had traveled to Spain. Okay, so you know he has the epidemiologic criteria. The second one was it has an intimate contact with a social network, but that social network did not experience any monkeypox activity yet. And my third patient only has one partner in the last 3 months, only one partner. So it looks like there's already a transmission in the community. This is just the exclusion criteria. Remember, if you are testing for monkeypox, you need eye protection, a mask, a gown, and gloves, and you have to collect specimens from 2 lesions, and you have to decontaminate the surfaces after that. And if possible, you isolate the patient. Management. Okay, so in the United States, we have brincidofovir and tecovirimat, but these are not widely available. You have to get it from the CDC. We have the vaccinia immunoglobulin intravenous, and we have 2 vaccines. There's a live vaccine, it's replicating, the ACAM 2000, and the Jynneos, which is live but non-replicating. This is the one from Denmark, Bavarian, Nordic. So there's no FDA-approved treatments for monkeypox virus, but you know we have those several antiviral agents and the immune globulin. All of these are based on in vitro data, animal studies, and case reports. There are no randomized clinical trials that are available for this, because it's very hard. You know, how can you do a study against smallpox? It's already eradicated, and you know you don't want to use the smallpox from the American government lab. So these are the treatment options for severe monkeypox infections. So cidofovir is a drug that we use for cytomegalovirus retinitis in patients with AIDS, but it has severe nephrotoxicity, so we don't use this anymore. Brincidofovir is a prodrug of cidofovir, so there's no nephrotoxicity, but it can cause elevated liver function tests. Our best drug right now is tecovirimat, is IV and PO. And then, of course, we have the immune globulin, which is really FDA approved for complications of vaccinia vaccination, smallpox vaccination. Before, you know, if you have smallpox vaccination, you can have severe side effects, and the treatment is the immune globulin. So these are just the clinical, these are the reports of clinical use of antiviral agents in immunoglobulin. So they use it for vaccinia, cowpox, and monkeypox virus. Remember, there's no randomized clinical trials. And usually in this report, they combine 2 to 3 out of those 4 drugs, okay? This is the last one, the immunization. So there are no vaccines specifically designed to protect monkeypox virus, okay? So the current vaccines that we have, those are vaccinia-based, being considered, were developed for smallpox, okay? So remember that 85% cross protection rate. This is based on this retrospective study conducted at DRC or Zaire in the late 1980s. So in the unvaccinated household contacts, of individuals with monkeypox disease, the secondary attack rate was 9.28%. Okay, 9.28%. And the one for the vaccinated contacts, the secondary attack rate was 1.31%. So that translates to 85% protection. This is the basis for the 85% protection. It is not a randomized clinical trial. Okay, it's a small retrospective study. Now, what is the difference between ACAM 2000 and JNEUS? The ACAM is replication competent, so it has more side effects. The JNEUS is replication deficient. So ACAM 2000, you need those percutaneous technique with multiple punctures in a single dose. So that's why there's a take, meaning there's a scarring. You're gonna have scarring after ACAM 2000, just like BCG. JNEUS, no, it's because it's subcutaneous in 2 doses, 28 days apart. There's some data that probably 1 dose should be enough. A lot of risks for ACAM 2000, including myopericarditis, 5.7 per 1,000. That's pretty high. For the COVID vaccine, the myopericarditis rate is only 1 in 100,000, and maybe 1 in 10,000 in adolescents. But this is much higher. But most of these are mild, and of course the vaccinia complications that I mentioned earlier. Progressive vaccinia, severe generalized vaccinia could happen after ACAM 2000. JNEUS, of course, has less side effects. We actually did a study on HIV infected individuals, and the side effect profile was acceptable. So there's limited data and efficacy of JNEUS. Vaccination as post-exposure prophylaxis is recommended for persons who have high-risk exposures, and we'll talk about that later. So for PEP, that's post-exposure prophylaxis, the vaccine should be administered as soon as possible within 4 days to prevent infection, within 4 days, and up to 14 days to attenuate the infection. So even if they come in late, you can still decrease the number of lesions. There was actually a study, I don't have the slide, there was actually a study, it was a outbreak in 2003 in the United States. There were 28 persons who were exposed to monkeypox, and 8 patients had smallpox vaccination. So that's really pre-exposure prophylaxis. 8 persons had smallpox vaccination. And out of those 8, 3 did not have lesions, and 5 had an average of 3 lesions each. 3. The 20 other unvaccinated cohort had average of 33 lesions, so 10 times more lesions than the one who did not than the one who had vaccination. Vaccination as pre-exposure prophylaxis is currently recommended for lab personnel, handling orthopox viruses, but it might be expanded to include men who have sex with men. So right now in the United States, there's probably about 2 to 3 million who have high risk for monkeypox, and we only have I think 1.1 million right now. I think 400,000 JNEUS vaccines, and then I think 800,000 is coming in. So that will not suffice. Although they already ordered, I think 8 million more. The ACAM 2000 though, United States 100 million of these vaccines, 100 million. The reason they're not releasing it is because it has a lot of side effects. If you give it to patients with HIV and they're immunosuppressed, you can kill the patient. So it has too many side effects for immunosuppressed patients. As remember, 40% of the patients who were affected are HIV infected. Although they're taking HIV medications and their immune system is much better. But yes, they have 100 million doses of this ACAM 2000. Abstinence during active infection and up to 8 weeks after recovery has been recommended in the United Kingdom, because this is based on the studies showing that there's virus in the seminal fluid. This is controversial. So post-exposure prophylaxis, what is considered high risk? If, of course, you have unprotected contact with the lesions, and if you are within 6 feet of a patient during any procedure that may create aerosol without wearing N95 and eye protection, okay? So that's high risk. Intermediate risk is within 6 feet for 3 hours without a surgical mask, okay? Or wearing gloves but not wearing a gown. So this is intermediate risk. So the PEP indication is case-to-case basis. And low risk, if you are within 6 feet and you are not wearing a surgical mask and it's less than 3 hours, it's still low risk. Okay, it's still low risk. These are the contraindications for the ACAM 2000 and JNEUS, because a lot more for the ACAM 2000 because it's replication competent. So you cannot give it in patients with atopic dermatitis. Otherwise, they're going to get eczema vaccinatum. Those with immunosuppression, they'll have a progressive vaccinia, pregnancy, infants, breastfeeding, and underlying heart disease because of the myocarditis. So this one is just, these are just quotes from an article. It's actually a review from the Open Forum Infectious Disease. And it says here, similar to the early days of the HIV/AIDS pandemic, clustering of cases in men who have sex with men has sadly led to stigma directed towards this group of people. So all the resources should be focused on identifying cases in social networks emerging as having a high risk of exposure. The core of public health messaging should be supported and free of judgment. So remember, infectious pathogens do not care about race, gender, or sexual orientation. Thank you. That should be my last slide.
Wow, okay. Thank you so much, Dr. Frank.
Thank you, Franco. Grabe. Grabe. One of those, one of those jaw-dropping, the clapping, all the hearts. I really thought the photographs were so helpful, Franco, because the pictures that we see online are just the ones on the on the hands, mga ganyan. So I thought that was really very good, no? And I think we have a lot of points to discuss. But thank you. I know you spent time doing the research on this, and our audience really appreciates all the information you have given. Okay, so we are going to sorry, we're going to move to our next speaker with Raymond. But before that, I just wanted to tell our audience, you're talking to a Filipino doctor who was diagnosed and treated monkeypox. Only on Stop COVID Deaths will you see this. That we will see Filipino doctors who are sharing their information with us, despite they're working in other parts of the world. No, so this is a Filipino doctor who has diagnosed and treated, managed monkeypox. Ang galing, no? Parang sabi ko, ang galing ng sharing. Parang meron tayong ability to to use our mga kababayan sa ibang bansa na makatulong sa atin dito dahil wala pa. Parang hindi na tayo mag-aantay ng anong gagawin. Meron na tayong natututunan. Anyway, Raymond, over to you to introduce our another very special speaker. Go ahead.
Yung ating very special speaker, suki na po siya natin, Dr. Susie. Infectious disease specialist din po siya. Very much beloved by our viewers. She is, again, the head po ng Philippine General Hospital Infection Control Unit. Please welcome again to the webinar, Dr. Nina Berba. Dr. Nina?
Hello, good afternoon po everybody. Nakaka-nervyos sa sumunod kay Dr. Franco.
Oh, hindi naman.
Anyway, ako ang aking lecture ay entitled it Monkeypox Disease Practical Points for Response.
Thank you, ma'am.
So, para hindi kami mag-overlap ni Dr. Franco. No? So, just to remind everybody, hindi pa kailangan masyadong magpanic. The number of monkeypox cases confirmed in the Philippines is only 1. Pero this is very important kasi we call it an outbreak. Wala naman talagang monkeypox dito. So I'd like all our viewers to be aware that there's a department memorandum from the Department of Health trying to guide us as to how the response should be. So this came out in May of this year, and it's very comprehensive. Over the weekend, nung in-announce na nga that there was monkeypox that was confirmed here in our country, the Philippine Society for Microbiology and Infectious Disease came out with a briefer. And it's in their website. I posted here the website of PISMED. You can access it. So you'll have the full document. But I'll discuss most of what's in there in my lecture today. So why do we want to have a good response, diba? Up-to-date, relevant response to the monkeypox? Repeatedly kanina, we heard about how WHO, Dr. Tedros actually did declare that this is a fake, public health emergency of international concern. And it's really because we really want all the countries to be more involved and have that global solidarity to stop this from evolving into something far worse. So I think if we were going to identify the objectives of our response, it should fall somewhere here. Kung pwede nga lahat, no? Number 1 is to identify the cases efficiently. Number 2, to reduce new cases. Number 3, to reduce confusion. Number 4, to reduce stigma. And number 5 is to protect our healthcare workers. So it's very important, I think, for our responses parang on an institutional level, collectively, individually, kasi we don't want to lose our patients. We want them to come to us and be diagnosed as efficiently as possible. Imagine kung paghihintayin mo yung pasyente ng matagal sa emergency room or hindi mo siya papansinin or he doesn't get the answers. We'll lose these patients and we won't know who among us may have this monkeypox. And that's important because we really don't want to have new cases. We'd like to reduce the risk for the new cases. And we'd like to inform the cases so dapat alam nila na case sila and they don't cause more cases. We also want to reduce confusion, and that means to share reliable information to the public. And most of all, I think we really want to reduce stigma. We don't want to stigmatize certain groups. And the frontliners, so may frontliners pa rin, and most of us in this audience maybe belong to that. We want all our healthcare workers to be aware of the risks and reduce this identified risk in our own practices. No? So what I will discuss is number 1, facility response, how to assemble your pathway and networking with RESU. Number 2 is the clinic response. What if certain individuals or certain groups in your hospital would also want to manage suspected monkeypox cases? And number 3, what could be our best responses to frequently asked questions? What to tell our patients? So in the Philippines, we follow the international case definitions. So this is the suspected case. So Dr. Franco discussed this a little bit earlier. A person of any age with unexplained acute rash and, so may end on, any one of the following: headache, fever, myalgia, back pain, asthenia, lymphadenopathy, and for which the other usual causes of the rash probably is not true. So that's the suspected case. Parang maraming magfo-fall under suspected case. So as much as we'd like to be vigilant about them, we also want to be selective. Ayaw naman natin lahat ipadala for PCR testing for monkeypox. And then the probable case, parang mas malapit to sa totoong case, is when there's an epidemiologic link. No? So that means there was face-to-face exposure or healthcare worker exposure or travel to monkeypox endemic countries in the past 21 days or has a history of multiple sexual partners in the last 21 days. And then, of course, the confirmed case are those whose specimens sent to the RITM. So for now, we all send our specimens to the RITM. Was found to have the PCR test for the DNA positive. And then there's this definition of contacts. So tayo bilang healthcare workers, we hope we won't be labeled as contacts. So even if you do eventually get to manage or treat or try to be part of the team to diagnose a suspect case, you have to be fully protected so you don't fall under the contact. Yung diniscuss kanina ni Dr. Franco, yung low risk, high risk, no? So we need to have our PPEs in place. And then those who were suspects and then eventually found to be negative will be called, in our terminology, a discarded case. So I think it's very important in step 1, 2, 3 that I will show in this slide is to figure out who among your patients, yung perf nyo in your facilities, in your regions, in your provinces, who are at risk to get monkeypox. Yan yung first question. And where will they most likely go to your facility? What clinic, what part of your hospital would you have to really empower to be able to meet these monkeypox suspects? And number 3, how can we make the process safer and more efficient? So to answer those questions in our facility in PGH, yung question of who are at risk, who among our patient populations, those who come to our hospital, would fall under those at higher risk for getting this monkeypox. So our answer there is we really are taking care, in PGH, we are really taking care of a large community of persons living with HIV. So we take care of a huge MSM community. So we need to inform them. So last week when this erupted into the news, we already started, or even before, we started telling them about this, posting posters where their clinics are. We also have a large infectious disease group of healthcare workers, derma, OB, urology, and general surgeons, all of whom may probably be asked or have to manage patients who are suspect or probable cases. So they also need to know they're part of your clients. No? And then where will they enter your hospital, or will they enter your institution? So we think most of these patients will go to our STD AIDS clinic. Pwedeng di nga nila alam may rash sila. Tapos you as the healthcare worker taking care of them in the SAGIP unit will probably see this rash and alert the patient, uy, may rash ka. Yan. Or maybe if they have a rash, they will go to the dermatology clinic. So we think that's a hot spot in our outpatient unit. And then, of course, the emergency room. Pag biglang may nakita siyang rash, tapos he feels this is very urgent, he may go to the emergency room. And then how will we form this pathway so that it's safe and efficient? So we need to set this up before the first patient comes. Get all the needs for the diagnosis, yung kits, yung PPE, plus set up some kind of an ambulance system or a courier system that will bring the the samples for diagnosis to our ITM. And of course, work on the networking with our local epidemiology bureau or the RESU. So our institutional or facility response, parang it boils down to 2 main points, which is placed in the department order of the DOH. One is to identify an isolation area. So I'm sure most of you here who have been in our journey for COVID-19, parang dami-dami na nating isolation areas na we've prepared. But now we're asked to prepare another isolation area again for suspected monkeypox. This needs to be like dedicated. Hindi siya pwede mag-mix sa TB, can't mix with the COVID patients. It needs to be its own isolation space. No? So in your in your space in your hospital, try to find a smaller space. It doesn't need to be extensive. It just has to be dedicated for the next monkeypox suspect case where you will see him. And then have a process. So have a process from the time, think through a patient coming in to your hospital, asking questions, saan siya pupunta, where next, what happens to the diagnostic kits, who brings them to our ITM, can we discharge the patient, can we send them home, how will we follow them up? So this process needs to be written up and worked on and modified accordingly. So I'll show you the evolution of our pathway. Kasi parang over the last few days, we actually worked on this. Initially, when I was like thinking in my head where else can we put this this isolation area, we actually did put up a tent near our ER. Sabi ko, tingnan mo na siya kasi hindi na siya kailangan pumasok. He doesn't have to enter the main emergency room anymore. If the concept is to refer all the cases to RITM, then he can just sit down in the tent and wait for the ambulance to bring him to RITM. But the more we thought about the pathway, the more it seemed very insensitive to put them in the tent. So parang na-scrap. So if you're thinking of a tent, just don't do it. It's so parang insensitive. It's so open. Everybody's seeing, pag maglalagay ka pa ng for monkeypox cases only. So parang kita na ng lahat ng tao na ito na yung persons who's waiting for his ride to the RITM. So I thought that was going to add to the many problems that we think will happen. So yeah. So we ended up having this very complex. Initially simple, nagiging more and more complex. But it's important for us, pag may rash, to work on a checklist. And that's available in the department order. And that was also parang laymanized by the PISMI document. So you have to parang ask the question, do you have a rash? Is the rash associated with, that's on the square on this slide. No? And then if the answer is yes, are there other factors to consider? So is there travel history? Is there like an epidemiologic link? Do you have contact with somebody who may have monkeypox? So all of this needs to have parang a documentation. Meron na kayong 1/4 sheet of paper that you prepare. And the healthcare workers then can go ahead and ask these questions. And then alongside, the PPEs need to be ready. It can't be that you wait for the first patient and then you struggle to look for them. So in the PGH, we have what we call level 3. So that's sort of clear to us. So you need the mask, you need the eye cover, and then you need the gown and gloves. Okay, and all the numbers here. You would see that there's already monkeypox likely after the screening. So the pathway will be different if the answer is no and if the answer is yes. Initially, we decided that we were going to admit all cases where the answer is yes. But actually, that's one of the things I learned from my communication with Dr. Franco, that not the monkeypox cases may actually not need to be admitted because they may not be sick. So there is an option to be discharged. So we worked on that. And soon it became a little bit more complex. There were more things that we considered. We now involve the derma resident, the infectious disease doctors. We identified who's going to do the swab, who's going to collect the specimen. That needs to be identified. Hindi magtuturoan pag nandyan na si patient. It needs to be parang fluid. People know what to expect and people know how to take care of themselves. And then, of course, the DOH said they do not have the funds to finance the courier service from wherever you are to RITM. So that needs to be worked out also. Who brings the specimen to RITM? And then if the patient is not admissible, can we discharge? And how can we safely discharge? So you have to talk about that too. So eventually, we now have parang here a dedicated space in our emergency room, Department of Emergency Medicine. And then it became clearer who's going to collect the specimens and assess if the patient needs admission. And that's the only time we decide to admit the patient. Otherwise, there is an option to send the patient home. Okay, and now this is our final as of today. Yeah, we thought about maybe it's going to be safer and more efficient if we don't dump them in the emergency room. So if patients are already in the clinic, maybe if we put a small space within the Sagip clinic, and maybe within the dermatology clinic, there's an identified space that they can work on, then we don't have to like move and transport the patient all the way to the emergency room and congest our emergency room. So only the patients who will be brought to the emergency room or who would walk into the emergency room may need to be seen there. So it needs tweaking and trying to find solutions for everything. And then it's the dermatology group who said, maybe we don't need to refer to too many specialists, like maybe just as a backup, the urology, the OB, and the surgeons. Maybe we don't need to have them to see this patient right away, only if needed. So that made the pathway a little bit better. So in screening the rash, we have to think about monkeypox ba to o hindi? So that's based on the appearance of the rash and how it looked like. And of course, the other links, the travel history in the past 21 days, history of multiple sex partners in the past 21 days, and epidemiologic links. No? So as I said, it's good if you can have this checklist ready, whether it's a virtual list or an actual list in printed 1/4 sheet of paper. It's good to have them so our staff won't get lost along the way. And then there's the CIF form. So it's not as simple as it seems. It's like COVID-19. May mga forms you need to fill up. And it's important to fill them up right there and then. So when you start thinking about, is this monkeypox, we have to answer the questions because the RESU or the CESU, these are the epidemiologic surveillance units in your locality. They won't approve your request to send specimens to RITM unless they see that it's really more probably close to a probable case. And then in the department order, there's also the instructions, step-by-step instructions on how to collect. The specimen we'd like to collect is either swab of the skin lesion, or the roof, or the scab, or the vesicle top, or the crusts. No? Kung wala dun, pwedeng oropharyngeal swabs. So that was discussed earlier by Dr. Frank also. So before you decide that ready na kayo, you need to have all of these swabs, no? And the specimen kits. And how to collect. There's actually a YouTube that was prepared by the RITM to see exactly how to do this. Di siya mahirap. And then I want to just say that even if there's this monkeypox outbreak right now that we're working on, not all rash is monkeypox. So there's dengue, there's syphilis, there's chickenpox, and all of this. And that needs to get into your, like, just through your differential diagnosis. Okay. And if it's needed, then do the serologic test. So maybe test for an RPR if you think this is syphilis, or test for dengue, like dengue NS1 or dengue IgM, depending on the period of time that the patient came in. Or it can even be non-infectious, like hypersensitivity reaction. So all of that needs to come in. And where to send the specimen? So nakasulat doon, you need to send it to the RITM. But again, make sure that you get the approval of your local units because they won't accept it. So sayang yung specimen. So what we're thinking of doing is perhaps when the patient comes to our, let's say, OPD clinic or Sagip clinic, to go ahead and get a sample and then store it first while we're waiting for the RESU or the CESU to give us our go signal to send. What if some doctors also want to actively diagnose? So meron kayong mga standalone derma around you na we don't really want them not to be part of this. So this is really a welcome gesture of volunteerism. So ako, kung gusto ng derma to be part of this, of course, but just coordinate with the RESU, with the EB, with the DOH, or with your local CHD. I would think that many patients, yung numbers dito are my own thoughts. How many will consult derma? Siguro 80%, siguro 10% urology na yung mga males who suddenly have something in their genital areas. Or maybe the pregnant mothers will go to their OB. Yeah. So many people will maybe consult different kinds of doctors. So we need to just let them in, but coordinate accordingly. So a little bit more on infection prevention. I borrowed the slides from the PISMID, so they have a core set of slides. So again, this was already discussed, pero remind natin, hindi masyadong kailangan mapraning, diba? Kasi kailangan mo talaga ng contact with body fluid, skin lesions, prolonged contact na yung sinasabi, human-to-human transmission. So it requires close physical contact. Matagal kayong magkasama at holding hands, yan. And it could be sexual activities with or without genital penetration or non-sexual activities. Okay. It can also be exposure to respiratory secretion, so that dun magfo-fall yung fomites also. And in the healthcare setting, we really want to stress that yung equivalent ng PGH level 3, whatever you call it in your hospitals, basta kailangan ng gown. Kung hindi pwedeng single-use gowns, then pwedeng laban yung gowns, the cloth gowns that will be cleaned later on, disposable gloves, N95, and an eye protection. Non-negotiable to, hindi pwede mag-downgrade. This was asked in one of the fora. We said this is non-negotiable. All healthcare workers who decide to see patients with monkeypox needs to, at the least, wear level 3 or the equivalent. Okay, so we're going to practice in infectious disease what we call contact precautions and droplet precautions. Okay, droplet kasi there's this possibility that kung nagka-cough siya, pwede through respiratory droplets. And some of the things I'd like to really just point out that persons are not infectious until the lesions appear, diba? Walang prodrome. Kaya in a way, this is really much easier than COVID-19. And the isolation, there is an end point. Hindi siya forever. No? So infectious until all the rash dry up. Very, very similar to chickenpox. No? So when the vesicles dry up and the scabs have fallen, then hindi na siya infectious. So again, make sure that there is a screening for patients who come to you with a rash. Tapos the next slides are parang recommendations for certain groups of higher risk populations. For our recommendation for our MSMs, ito kasi tatanungin kayo bilang healthcare workers, ano sasabihin nyo? So, reduce number of sex partners. Kung may bagong sex partner, isipin mo ulit muna. Maybe talk about it. Get contact details with any new partner so that if eventually you need to follow up, you know how to reach them. Again, this is in the CDC also. So talk to your partner. Kasi, for example, ako, I take care of a lot of HIV patients. So they will ask me, dapat straightforward, masagot nyo yung mga tanong nila. So if you or your partner have monkeypox, wala mo ng sex, stop, no kissing, no holding hands, do not share towels, yung mga ganon. So try to be more familiar with this. So when they ask questions, you'll be able to answer. Tapos, syempre, minsan, kasi parang COVID-19, diba? Kala natin nung dineclare ng March 2020, ako, in my mind, kala ko hanggang June tapos na yung pandemic. But here we are in 2022, we're still in the pandemic. So baka mo ganitong question na yung monkeypox. Baka telling your patients na wala mo na sex, baka naman hindi nila kaya yon. So you need to also discuss alternatives. So CDC and the Public Health England gave some recommendations on what to do pag kailangan talaga na may sexual contact yung some of your patients and what they can do. So eto nakasulat dito yung have virtual sex, no in-person contact, yan, and all of this. Parang mahalaga to say talaga, no kissing. Parang ko yung sinasabi, no kissing muna. And then the use of condoms may help, but it will not really maybe 100% prevent monkeypox. So talagang stop the exposure. Okay. Tapos what if nag-share, no? Nag-share or tapos na, nag-sex na. So remember to wash hands, clean all the stuff that were used, and most of all, avoid touching the rash. Meron nga dito, ito mahalaga to sa atin kasi minsan even our youth get involved in parties, raves, clubs, or maybe festivals wherein the risk may get into like that level of activity wherein it may be already encroaching on risky behavior. So kailangan ganito, sabihin natin, yung mga anak ko, wala yan. Please avoid getting yourselves into situations wherein hindi nyo na makontrol. Okay, so avoid parties or clubs where the audience may have minimal clothing. Yan. Tapos don't get into situations like sauna baths, sex clubs, yung mga ganon. Minsan meron tayong mga pasyente na gano'n yung discussion nyo eh. So there is science into it and you can discuss it with them. Okay, so what to do? Tinanong ka over telehealth. So ano pong gagawin ko dito sa rash? Okay, so immediately kung may rash, hindi nyo pa ma-assess kung monkeypox or hindi, then really request that person to avoid sex altogether, especially loved ones, don't expose them first, and then seek consultation to a health provider. When they go, for example, to the OPD, tell them, make sure you wear mask and volunteer relevant information. Wag na magtago ng mahahalagang information about exposures, and then avoid gatherings. Okay. Ito naman, ito yung tanong eh, Doktora, nakakatakot yung monkeypox kasi are the lesions here to stay forever or will the lesions improve? Di ba yung mga smallpox, it was the reason why many people really became very afraid and almost stigmatized other groups kasi ayaw nila magkaroon ng ganitong klaseng lesions. But remember, this is also self-limiting na. So within, yung nakasulat dito, 2 to 3 weeks, lesions will scab over and resolve. And then the person will no longer be contagious. Pwede magka-scar, pero even that will improve over time. Okay. Recovering from monkeypox at home. So we're getting ready to translate this to Filipino. So this is available in the WHO website. So just that you know na ito. Basta make sure when we have rash to always clean our hands, don't scratch, try not to, yun yung sasabihin nyo sa patients, whether monkeypox siya or hindi. Try not to scratch, don't touch the lesions, keep the rash dry. You can keep it uncovered if you're just at home. And then, one of the things that are important sa monkeypox, namamatay yung virus with alcohol, with the usual disinfectants, with the Clorox, chlorinated solutions, and with the usual soap and water. Okay? Yan. So, pwede maligo. That's part of it. Pwede maligo, basta wag masyadong ma-irritate yung wounds. And then take care of your mental health. I'm sure this is another reason why people will get overly anxious. So have in your institutions a way na they can call somebody. So sa hospital namin, HICU yun. They can call HICU anytime, our Hospital Infection Control Unit. Tapos yung question, kailangan ba sila lahat admit or pwede ba sila magstay at home? So the answer is yes, they can stay at home. And this poster, again from WHO, tells us that there are ways. It's easier nga to isolate people with monkeypox than those with COVID. Kasi noon with COVID, very, very strict. Kailangan separate bathrooms talaga. Ito nga, pwedeng may bathroom, pwedeng may shared bathroom as long as it's disinfected after each use. And again, we don't want sharing of utensils for now while patients are actively sick. Pero they could be washed. Hindi kailangan itapon lahat ng mga gamit, di ba? Pati clothes, hindi kailangan itapon or i-burn. They could be washed safely. On the right side, you see that if you can't avoid being in the same room as someone else, then cover the rash with clothing or bandages. Wear the medical mask, open the windows, and clean your hands often. Okay, so then some WHO, there's also the Q&A. So I just chose like 3 questions that I thought might be something that you will also be asked. So is there a risk that this will become a pandemic? Dr. Franco said parang hindi, no? So what it just tells us right now, and I really also thought that it's important what the WHO did to declare it a public health emergency of international concern, because this gives us a window of opportunity, no, to really learn as much as we can and protect each other, protect even those who are at risk para hindi sila magkaroon ng ganitong klaseng illness, and reduce the number of cases we will have in our country. Can people get seriously ill or die of monkeypox? So I did say that hindi lahat kailangan i-admit. In fact, Dr. Franco said just like about 13% needs to be admitted. And most of them will be admitted because of pain. Pain control like proctitis yan, or maybe some complications. But most of them will do well at home in isolation. There's been some deaths that have been reported abroad. And then we just really need to watch out. May question kasi nga yung children pwede magkaroon by virtue of close contact, let's say with caregivers or parents. So may question about, can I continue to breastfeed if I was diagnosed to have monkeypox? So the answer of WHO here is it needs to be carefully balanced. So ayaw mo naman na deny the baby of breastfeeding. There's ways of reducing the contact, the skin-to-skin contact between the baby and the mom. No? So that needs to be just ironed out and discussed, and the patients need to be taught very well. Para hindi magka-monkeypox si baby. Okay, yung last part na ng aking talk, tama o mali? So put your answers on the chat box. So I thought of like what the anxieties would be of your staff in the hospital. So kunyari, this one, I'm a security guard at a government hospital. I assisted an elderly male by pushing his wheelchair. So yun lang yung contact nila, no? Later, I learned that he had a rash in the chest. The security guard says to you, I thought about monkeypox. I heard also that our ID section doctors assessed the case and said it's unlikely monkeypox, and instead it might be varicella zoster. But I became very afraid. So what I did was I decided to burn my uniform I was wearing that day. Tama ba yun or mali? Kailangan ba i-burn yung ating mga nagamit for the remote possibility that we were splashed with monkeypox droplets? So ano kaya sagot niyo? So ang sagot doon, sagutin ko pala, hindi ko pala naisip para sa sagutin. Let me check the FAQ. So, ang sagot doon ay hindi kailangan i-burn. Hindi pa kailangan i-burn scrub suits natin, mga damit natin, kahit na mag-confirm nga siya na monkeypox siya. We don't need to destroy the clothes. They could be washed well. In the United States, there are washers na may option to wash them in hot water. Pero here, we wash them. They could be safely laundered and then dried in open air. Okay, the virus is killed by usual disinfectants, open water, alcohol, etc. The same goes true for yung magkaka-monkeypox ba ako if I touch the doorknobs, yan, the switches of the yung mga switch para sa ilaw, yan. So, kailangan lang in our institution, the same vigilance we had for COVID-19, di ba? Keep on like surface disinfecting all the areas that are frequently touched. Do the same for monkeypox. Okay. FAQ number 2, I'm a TB dots nurse and we get a lot of referrals of HIV patients with TB. Now that there's monkeypox in our country, I will not accept referrals anymore from our HIV clinic kasi siguro this TB dots nurse is thinking baka meron siyang dalang monkeypox. Tama ba yun or mali? So this is exactly what we're trying to avoid, diba? Ayaw natin mas stigmatize certain groups. Ayaw na natin mas maganda na we don't get into this, cascade of wrong information. So ang sagot dito, definitely is mali. Okay. And the last question, ito, my husband is an OFW in Spain and coming home next month. Pero ako, I don't really want to sleep with him even if I miss him very much kasi he may be a carrier of monkeypox. Tama ba yun or mali? So, if a patient will ask me this question, I will tell them to, as husband and wife, to talk about it. Kasi kung si husband meron siyang mga risk factors or naging risky behavior during his stint in Spain, then baka naman meron bearing yung iniisip ni wife. No? Pero kailangan pag-usapan, hindi dapat husgahan yung ating mga heroes who are working abroad just because they're working in places where there is high cases of monkeypox. So yan, kailangan pag-usapan ang tamang sagot dito. Okay, so in summary, this is what I think monkeypox preparation should include. This is number 1, identify a dedicated area and process in your facility. No? Number 2, start information campaign. So include everybody, staff, including security guards, diba? Dapat alam nila, hindi pwedeng, oh no, merong monkeypox na diagnosis sa them, tapos guard pala siya doon, tapos hindi niya alam. So magpapanik siya talaga, baka ipileda, masunog niya lahat ng kanyang uniform. So staff, patients, everyone under you needs to have this part of information campaign. And number 3, it's very important to build the network with your local EB units, yung surveillance units, we call it RESU, CESU, the LG, the CHD, and start being friends with them. I'm sure through COVID, you already established these linkages, so continue to work with them. And step 4, to modify and monitor your process and modify accordingly. Yun, that's it. So if you have any questions, don't fail to send me an email. I also want to give credits to Hiku, to IDS, and to Pismid, from whom I borrowed some of the slides. And of course, ito, yung template I use slides go. Thank you. That's it.
Okay. Thank you very much, Nina. Naku, we're all blown away by this. Palakpakan naman natin si Nina. Grabe. Ang galing. I think, yeah, we're clapping. You can see that while you were talking, Nina, may mga heart, may mga puso. I think you gave really very practical advice, which, you know, our audience who are in far-flung areas, ngayon lang siguro nila na naririnig itong mga kailangan nating gawin para maghanda. Madali kasing sabihin na maghanda tayo. Are we ready? But I think you really broke it down into, you know, up to the level of where do you put the patients, etc. Ang galing, very good. So thank you so much, Nina. We know you're busy, but thank you for being with us. And we've got so many good questions in the Q&A. I'm itching to go into the Q&A. I think we will only have 2 or 3 questions, but let's go, Raymond, to our next section.
No problem, Dr. Susie. And thank you again for that comprehensive presentation, Dr. Nina. And I hope that's something na baka may gagayahin na, or at least a guide, yung iba pong mga hospitals. We'd like to invite also Dr. Felizarta to open up his video po as we prepare to into going to our Q&A session. But before that, let us take a quick break for a special public service announcement today.
Aloy, bilisan mo! Dali!
Wala! Ha? Ano nangyari? Ba't hindi kita makapitan?
Handa ka na ba, Kaloy?
Oo naman, ate! Nabakunahan na kami. May powers na kami laban sa inyo.
At hindi nyo na kami basta-bastang makakapitan. Yehey!
Sisiw!
Kaya mga bata, magpabakuna na kayo.
Stay safe and stay well. Mga bata, magpasama na sa Bakuna Center. Thank you so much, TVUP. The COVID Communication Public Service Announcement is one of the many creative outputs of the Stop COVID Deaths team to push for pediatric COVID-19 vaccination for children aged 5 and up. Dr. Susie?
Yeah, thank you. Let's go to our Q&A. And I had this very nice question, pero let's go na lang to the ones in the chat box. So, into the Q&A. Raymond, let's go ahead. You pick the questions. Kasi daming tanong ng ating, I'll ask also our doctors to try to answer them in the Q&A box. But Raymond, pick up the more important ones. We can do 2 questions. Yeah.
Okay. This one is something that we repeatedly have been seeing, not just for today's webinar and not just in the YouTube and in Facebook, but in previous webinars po. This comes in from our Suki also, Dr. Joseph Tortona. Will the MMR vaccine provide protection against monkeypox or any other vaccines that we have right now? Will any of them provide protection against monkeypox? And if so, will an escape infection be of less severity? Dr. Franco?
Oh yeah, definitely not. MMR will not give you any protection. It's entirely different virus. Even sometimes they actually think chickenpox is also a pox virus. Remember, chickenpox is varicella. It's actually a herpes virus, very different from a pox virus.
Thank you, Dr. Franco. Kasi if you saw also in our chat, there have been observations that they think that it looks like a herpes lesion. So there might be some misconceptions na baka pwede po yung any of our vaccines that we have.
Raymond, before you go to the next question, I just wanted to pick up something that Franco said that I thought was really very, very, very important from a public health communications point of view, was that you could have 1 lesion. 1. Kasi what you see in the pictures is yung marami, yung talagang full-blown. Pero ang sabi niya, pwedeng 1, pwedeng 4. Diba? Tapos they're in the places where the sun don't shine, right? It's like, there are places where people don't usually look at some of these places. But I think the other thing, tatlo no? The third one was that it's not tender, hindi masakit. Usually patients will consult because of pain. So I think these are messages that were really very, very important in a stage where we want to look at the early diagnosis of monkeypox. Anyway, that was just a comment. Go on to your next question, Raymond. Na ano lang ako ron sabi ko parang yun yata yung kailangan natin
Importante yun.
i-communicate.
Kasi people
Diba?
will assume
Hindi
na
masakit.
kailangan marami bago So,
Oo, yung pala iisa tapos sa lugar na hindi mo makikita, nagtatago siya. I don't know. Wait, Franco, you wanna describe a little bit more how hidden the lesions could be?
Well, my first patient, it was easy because it's in the shaft. Pero yung second patient, he only saw it after he shaved, which is actually not recommended, because if you shave over the monkeypox lesion, you can actually make it worse. So, but that's
in the
point.
pubic area. Franco,
Yeah, it
in
was
the
in
pubic area.
It was in the it was not in the penile shaft itself. It's in the suprapubic. It's in the pubic area. So when he shaved it, he saw it, and there were like 4 lesions.
Ayun na nga,
Yeah.
where the sun don't shine, they're there. I think it's hard. That's very difficult. Yeah.
And
Okay.
it was not tender because when I was swabbing it, there was no problem. Although the one that's near the urethral opening was very painful. So if it's near the mucosa or, like the anal mucosa, it will be very painful. But if it's just in the penile shaft or genital area, it doesn't look like it's painful. It's non-tender.
So Franco, you think if someone had one lesion and they recognize it and it looks like monkeypox, would they stay home and just, wait for it to go away?
Yeah,
Ganun.
yeah. It's just so it was dying. You're thinking, the patient actually he didn't go to the doctor. Hindi pa pumunta sa doctor.
Kunyari, self-diagnose lang siya.
Oo.
Nakita niya. Hindi masakit, di ba? Non-painful lesion that looks exactly like your photographs. In fact, I think those photographs need to be disseminated widely. Even the pictures that Nina had, no? Kasi, you learn by visualizing it, no? Parang, anyway, sige. Do you think people would just say, oh, okay, I've got monkeypox, I'm gonna stay home. Parang hindi na magkaroon ng marites, ng chismis. Nina, you wanna say something? Go ahead, Nina.
Ako ang parang take ko dyan, because nga of pwedeng konti lang yung lesions, is to always, for our ID fellows and persons and healthcare workers, doctors who are here, and you take care of some of the HIV patients or MSMs, parang make it like part of your kamustahan. O meron ka bang
Casual
dito
lang.
pansin?
Casual lang, right? Casual.
Yeah, tanungin nyo lang sila kasi most of the time Filipino patients, di sila nagsisinungaling sa mga doktor So baka they'll tell you, and then that's an opportunity to diagnose.
Nice. Okay, Raymond, we got one more question.
Okay. This one po is, we'll try to get from someone who, what do you call this, is asking naman po with regards to prevention. So this one for Dr. Berba, coming in from Ana Sofia Besa. Good afternoon. The only RT-PCR for monkeypox currently available is in our ITM. What measures are being taken to screen or test potential cases coming into the country if outside of Metro Manila? Have you heard of any plans for testing centers in other regions? And they're asking this in view of new variants being detected in areas like Western Visayas. Maybe it's something that they should prepare for also, Dr. Nina.
I think it's going to evolve through time. Parang ano pa lang yan, nagpre-prepare pa lang tayo. We don't even have the kits in PGH yet. We're still trying to access them. Tapos I think as soon as this is parang na-plancha na, then they'll move on to like going to the other regions also.
Yeah, so parang medyo, actually, maganda yung presentation talaga ni Nina. I encourage you guys to watch it again, no? Especially those who are in far-flung areas. Kasi preparation is not easy. As Nina showed you, no? Na parang, diba, you try something, it doesn't work. You switch to something else. And all hospitals are unique. Iba-iba yung, yung kakayahan nyo, no? So, panoorin nyo ulit para makita nyo talaga yung what are the practical things you might be able to do. Anyway, we are really out of time. I'd like to thank our guests, no, for really preparing for this webinar and sharing with our audience, who I'm sure very much appreciate all of this. And Raymond, you're gonna go to the answers to the quiz. O sige, go.
Okay, the two questions that we have, how is monkeypox transmitted? Meron po dito, 84%, at least in the Zoom, I'm not able to see it in, 76% in Slido naman po ang pumili ng all of the above. So, may we hear it from our experts? What is the correct answer, Dr. Franco?
All of the above.
All of the above. Thank you, sir. And then for the second question, for Dr. Nina, what should the healthcare workers use when seeing a patient suspected to have monkeypox? 89% says all of the above in Zoom, 87% in Slido. Dr. Nina, correct answer?
All of the above, correct. Kailangan may eye protection, ha? Don't get caught na mas flashan ka.
In Zoom kasi it is 0%. No one selected eye protection. So all
of the above.
All of the above. Thank you.
Okay, we're going to give our what do you call it? Our speakers a minute or two just to formulate their closing remarks. And while they're doing that, Raymond's going to do our evaluation. Go ahead, Raymond.
Thank you so much, Dr. Susie. We have 5 questions here and 4-point Likert scale po ang pagsagot. First question, this forms part of our evaluation poll. We are not sending a separate evaluation poll. Ito na po yun. So hopefully you'll be able to participate. The panelists demonstrated thorough knowledge of the topic. Number 2, the panelists were well prepared and organized. Number 3, the panelists spoke clearly and audibly. Number 4, the panelists use appropriate language with technical medical jargons adequately explained. And number 5, the panelists contributed to new perspectives and knowledge on managing various key health issues. We will not be closing this even after the messages. Hanggang dulo na po ito as we move on to the parting words of our speakers. Dr. Susie?
Thanks a lot, Raymond. Let's go to Nina first.
So I'd like to just encourage everybody to be prepared. This gives us a window of opportunity to prepare on different levels, no? Pwedeng on an individual level, kung sa clinic, sa institution, basta be part of this kasi this is something very new. We shouldn't be really scared about it. The more we know, the less the risks. So let's help our patients also in this another journey of another infectious disease.
Thank you very much, Nina, and thank you for joining us and for preparing that excellent presentation, which I hope our audience, especially in farther areas of the country, can learn from. Franco, go ahead. I know it's getting late where you are.
Yes, sir. Yeah, so don't underestimate the monkeypox. Everybody can be infected with this virus. Plus, we know that it has a high case fatality rate in children, probably higher than COVID. But at the same time, we shouldn't panic. Most likely, it will not be similar to COVID-19. It's not a novel virus. It's a DNA virus, a lower mutation rate. There's no airborne or pre-symptomatic transmission, so you can isolate the patient if they have skin lesions. The basic reproduction number is low. And we have antivirals. We already have antivirals and vaccines that are available. So we just have to be more widely available. Thank you.
Okay, thank you so much, Franco. And again, also thank you for preparing. I know you put a lot of time into doing this, but you're reaching so many people. Actually, now we've got more than 1,000 people who are on the live, on the playback. It's going to be even more. I'm very sure. So Maraming salamat, Franco. Okay, so Raymond, you want to do the quick evaluation results?
Okay, can we have it on the screen? Okay, there we go. So at least 92% for all of the questions po, for our audiences, they really strongly agree and they really like the topic. Like I mentioned po, dahil po suki po natin sila, they wouldn't be our suki if they really were not really crowd pleasers and crowd getters in that sense in being able to provide the latest and up-to-date scientific information on the current topic po. So thank you to our speakers for that, and you'll also be able to see that on the chat as well. Dr. Susie?
Okay, so we've missed her for a while because she's been very busy, but we would like to welcome back the Chancellor of UP Manila to do our synthesis and closing. Menchik Padilla. Go ahead, Menchik.
Magandang hapon po sa inyong lahat. So the monkeypox virus is here. So in today's webinar, we have two of our regulars, Dr. Franco Felizarta and Dr. Nina Berba. And allow me to just give you the highlights of the two presentations. Monkeypox virus was first identified in 1958 in non-human primates. It is a zoonotic virus, and the spread has been caused by the following, and please take note: deforestation, encouragement of animal habitats, population growth, increasing human mobility, enhanced global interconnectedness. And that really, is something that's happening in the whole world right now. Globally, there are 10 reported deaths. And talking about the virus, the monkeypox virus belongs to Poxviridae family and genus Orthopoxvirus. Napakahirap itong words na ito, no? It is, in terms of size, it is larger than COVID. Now, a large proportion of the global population does not have immunity because of the eradication of smallpox and the successful immunization program. Transmission is primarily through the large respiratory droplets during prolonged face-to-face contact or intimate contact like kissing. And then, although low, there is the probability of transmission through the contaminated fomites. We already know the various animals that can transmit the virus, but what we learned today is that there is no definitive animal reservoir that has been identified. It is endemic in 10 countries, most especially in the Democratic Republic of Congo, with a total of 37,000 cases. Overall, across all the countries, the case fatality rate is 8.7%. And take note that the younger, the higher the case fatality rate. Because in COVID, the older, the higher the case fatality rate. So this time, it is the young ones that are being affected. It's good to know, when Dr. Franco and again Dr. Nina said that it is unlikely that this will lead to a global pandemic because the transmission is not airborne. And good thing is that there is no pre-symptomatic transmission. The basic reproductive number is 2.1, much lower than the Omicron variant. There was a big discussion on antivirals and vaccines, and I'm not going to talk about that. But I do want you to watch the replay because the very visual presentation of the progression from the rash to the pustule and to the scab is something that we should all learn about. But I do want to mention that the lesions are from 10 to 150 and can persist up to 4 weeks. And the infectious nature is from the time of the symptoms until the lesions scab and fall off. Now, this is the part that's really, I found very interesting because Dr. Franco said that the 2022 outbreak is a bit different. There is a background of 98% MSM with 41% with an HIV infection. And 64% had less than 10 lesions, with 73% with anogenital lesions, with 54 having a single genital lesion. So I think, this only tells that when we examine a patient, we have to really have a complete examination, clothes off, so that we can examine all parts. And the last part here is that 29% have a concomitant STI. Now, the positive PCR is 26%, and 95% of those with HIV infection were taking ART. And I think, this information is very important for hospitals and the clinicians, knowing that this history is important for us to elicit when we have a patient presenting with a rash, no matter where it is. There is a in the replay you will hear on the extent of the coverage of the rashes, not limited to the face and the arms, but take note that we have a lot in the genital areas. You know, it bothers me to hear that there is an isolated anogenital lesion, and it is a reminder of the importance of a complete physical examination for those who are watching us. Now that we're talking about a rash and we talk about differential diagnosis, Dr. Franco said, of course, herpes and syphilis will be on top list, but herpes is painful. But just the same, every time you have a rash, then you just have to make sure that you rule out the other cases to make sure that you may be dealing either with monkeypox or any of the STIs. Now, in terms of diagnosis, there was a long discussion again, but just to mention that we have to suspect and make sure that we make a confirmation, and the confirmation is by PCR testing or the next generation sequencing. There is no FDA-approved treatment for the monkeypox virus. There are no randomized clinical trials yet, but there are suggested treatment options. And again, Dr. Franco gave us the options in his presentation. There are no vaccines specifically designed to protect this virus, but Dr. Franco talked about the ones that are available to help out our health professionals and those who have been exposed. So take note of this timing: vaccination within 4 days to prevent infection, up to 14 days post-exposure to attenuate the infection. Now, vaccination as a pre-exposure prophylaxis is currently recommended for laboratory personnel who perform the testing and handle the cultures, or let's say handle the infected animals. And a note there that maybe we should be including this as part of the population of MSM. Again, there was a discussion on to whom do you give the prophylaxis, and I will not go into that. You have to go back to the replay because it talks about the high, intermediate, and low, depending on how far you are from the patient who was affected. And I think that is an excellent discussion, especially for those who are staying in the hospital. Now, going to Dr. Nina talked about the practical points. And, you know, although today there is only one reported case in the Philippines, PGH is getting ready. And she said that, you know, you want to identify cases efficiently because you want to reduce new cases. We want to reduce confusion. We want to reduce stigma, and we want to protect the healthcare workers. Now, there was a long discussion, but at the end, she gave a summary. So I'm going to go directly to the summary. She shared what PG8 has done to prepare, and I want you to listen to her because every hospital is different. The first one, she said, identify dedicated areas and the process on how you are going to handle patients with rashes. Number two, she said, you know, you have to look at your population at risk. In PGH, we have a very large population of HIV and MSM. And we have to know the fields of specialties who are dealing with rashes. So in other words, when you talk about identifying the area in the process as early as now, even if you don't have any cases, you've got to come up with your algorithm because the PGH has come with an algorithm, starting with whether it is a rash and where to send the patient, where to send the sample, and getting ready for the next number of cases that will actually come to the doorstep of PGH. The second step of Dr. Nina is starting an information campaign. And she gave a lot of examples, but there are different levels of campaign. She talks about patients. She talks about the health professionals on how to protect themselves. But at the end of the day, she talks about everybody. She talks about avoiding the parties, the festivities, the concerts. And in terms of patients, she said, you've got to look at the populations and give them additional information like the MSM and those with STIs and HIVs. So information campaign is not limited to a sector. We've got to look at different levels on what kind of information you have to give them. The third step, she said, build the network. There's so much now at the Department of Health and the local government units. We've got to be connected. And I really like the part where she said that it's not only the doctors within our hospital. We've got to look at the doctors who are standalone practitioners who can actually join our network so that we can relay this information to them. The last step that Dr. Nina mentioned was to monitor and modify. And I think, this is what is important. And she has done this to PGH. They kept on changing the guidelines depending on things that were happening. And if you remember her presentation, wherein at first they had the tent and then removed it because it was very insensitive, and then eventually identified the spaces. I think, this is one thing we're going to learn and take away from Dr. Nina. It is a dynamic exercise for everybody in the hospital, because every time we see something new, then we've got to modify our plan. So the prevention, and I think, I just want to address the health workers right now. Level 3, especially for those from PGH, I saw a lot of people, are actually PGH right now. Any form of rash, you've got to be very careful, and, be careful that you look into it and make a diagnosis. She gave a long list of things we have to do at home and at work. And I think, at the end of the day, it's just being aware of how to protect yourself, your family, and your community. And I do want you to read the frequently asked questions of Dr. Nina, because I know in the hospital, you're actually getting into those kind of questions. So, in summary, the WHO has declared the monkeypox virus as a public health emergency of international concern last July 23, 2022. And declaring a PHEIC constitutes the highest level of global public health, enhancing coordination, cooperation, and global solidarity. And I think, this is also the direction of our government: enhancing coordination, cooperation, and national solidarity. As Dr. Franco said, the infectious pathogens do not care about race, gender, or sexual orientation. Dr. Nina said we just have to be prepared. And finally, at the end, Dr. Franco said, do not underestimate the monkeypox virus. We might be caught by surprise again. Maraming salamat po, and thank you again for staying with us. See you next week.
Thank you so much, Dr. Excellent summary. All right, so next week, we have a very interesting topic again next week, no? We are going, I'm sure you are all suffering from the high cost of food. Napakataas po ng presyo ng mga bilihin, lalo na ng pagkain. At we're seeing increasing malnutrition, particularly among children. We already had high malnutrition prior to the pandemic, but now I think with the high prices of food, lalo na. So we are going to talk about nutrition on our next webinar, and we will talk about how can you prepare nutritious food in a budget. Lahat tayo kailangan medyo nagdidisiplina na ng ganyan, di ba? Kasi talaga hindi naman tumataas yung sweldo, pero tumataas yung presyo ng bilihin. So dapat ang nirekomenda natin at saka gagamitin din natin sa mga tahanan natin, sa mga pamilya, to make sure that we do not have too much malnutrition just because the prices of food are going up. No, we really have to be practical here, and I think we should be able to spot malnutrition and to advise families and parents how they can make sure that their kids are not malnourished. So we're going to do that next Friday. Join us at that time. Raymond, over to you.
Thank you so much, Dr. Susie. That is our sneak peek po for next week. But before we conclude our program, we'd like to first acknowledge the very hardworking team by the Stop COVID Deaths webinar series. Sila po talaga ang heart and soul ng ating webinar series na ito. And then for those who are very busy, we have what we fondly call the SCD shorts. So you'd be able to watch ito po mga short consumable videos that we have. And then finally, all Stop COVID Deaths webinars are archived for viewing at the TVUP YouTube channel for your convenience. So we hope you'll be able to go to youtube.com/TVUPPH for all of those webinars. This formally closes our webinar for this week. We look forward again to your company during our next Friday. Sana po makita-kita po tayo ulit from 12 noon to 2 p.m. It's a date!
Together, we can stop COVID deaths.
So keep safe, keep healthy, and see you online!